exam goes on, we keep doing our best for you actually. All right. Every exam when it comes, actually, certainly we see some new questions all the time. This time probably we have seen one of them is a glenohumeral you know dislocation. That's one of the new question probably we have seen this time actually. All right. So anyways, guys, let's not take much time further and let's get started. Yeah, without any further delay, please confirm me if you can see the screen. That'll be really, really great actually. Okay, wonderful, guys. Please mention in the comment section if it's loud and clear. This is August 2024 recall. We're just starting the class actually. Great. That's wonderful to know, all of you guys actually. So here we go. Great. All right. So those are the exam candidates. I wish you guys all the best actually. Um, for your exam actually, and do well in the exam. I'm sure you guys are doing pretty amazing. This is the first question without any further delay because exam is going on and we are trying to give our support to you guys actually. Now this time parents come with a concern with the second pregnancy because there's a son who's already having Huntington's and want to discuss about the risk of the Huntington's on this current pregnancy. This is the second pregnancy. The history mom is given, is healthy, and the father is having the same thing, that Huntington's disease, also grandfather. So it's kind of like a familial gotten this Huntington's disease as well. What is the percentage to have that this current pregnancy, the second child of having Huntington's disease? Interesting question. May not be that difficult. First, you need to know that Huntington's disease is this autosomal dominant, is this autosomal recessive, is this X-linked. Okay, in every exam, certain type of things are quite a common. Like this, one of these genetic things, they'll ask you the percentage. Like either you need to know it is autosomal dominant or a recessive or X-linked actually. So some of the basics, dominant cases, that's like a 50%, and another thing, if it's a recessive can autosomal recessive case is more like a 25%. Like these are some of the basics regarding the so coming to this one, this Huntington's disease, this is certainly is autosomal dominant. Okay, since it was autosomal dominant, we will think this is more chances with it, like the 50% association actually. Okay, so one of the parents is affected, so it's like a copy of the gene, and it's like a 20. I mean, it's like a 50% that will be affected. Are we clear with this one? It was not a difficult question. It's not a much difficult question, I would say. Next, I would like to add here, actually, I mean, it's for the future. I mean, those candidates. We have seen a similar kind of question with a cystic fibrosis, actually. Now, quick question, in a cystic fibrosis, how much do you expect the offspring, or even in the current pregnancy, the kids is supposed to be affected? If it's a cystic fibrosis, now any guesses for that one? For the cystic fibrosis, what is the chance? So everyone is agreed that is the 25%. It's like a 25%. But we do have a question in past, like normally how we interpret. I mean, one carrier mother, one carrier father, or maybe one having disease. That is how most cases we do that. Now, if we just cross this thing, one carrier mother, one carrier father, then we can see this is the 25%. One out of four, that is 25%, is having the cystic fibrosis line. So this is the chance normally. Now, in cystic fibrosis in past, there is a question, and even in present days, I mean, there can be, or even coming days, it can be. Sometimes there's a tricky thing. The mother is a diseased one. Mother is a diseased one, and the another parent is a carrier. So there's like a two, and one of them is a full affected actually. Normally, whenever we see the genetic, it's normally both are carrier. But sometimes we have to see the question properly. Is the person is diseased? I repeat, whether the person is diseased or not. Okay, now if the mother is diseased and the father is a carrier, now will it be the same for the same 25%? That's my question. Will it be the same 25%? Now, if you cross now, if you make the crossing these things, now you will find now 50%. So even in autosomal recessive, there can be 50% if one of the parent is diseased and one of the parent is a carrier. Is it clear to everyone? So this is like two different type of thing. One is the left hand side, that is the very classic one, and the right hand side, it is uncommon but has been tested in exam in past. Clear everyone? This is like a trick in the genetic related thing. So this is one of the maximum trick that can come in one of the genetic. All right. Last but not the least, another popular thing about Huntington's. Huntington disease is a trinucleotide repeat disorder, right? Trinucleotide repeat. And in Huntington's disease, another question came in past. I'm not sure, it will be tested, in this current time, that what is the best or most appropriate way to diagnose Huntington's disease in one liner? Okay, it would be CT scan, it would be radiology, it would be brain biopsy, it would be like genetic testing. So, what do you think? What is the right answer in this case? Final answer in this case is a genetic testing. Final answer in this case would be genetic testing. This is another popular thing. And another question came from Huntington's in past. They will give you the scenario like a chorea, that's like Huntington movement. Okay, then there are some dementia changes. All right. So they will ask you to make a diagnosis. It won't be much difficult for you to make a diagnosis for Huntington's. In our SMA notes section, I mean, this Huntington's disease related, there is a separate note on the genetics, right? Did you guys follow that one? I hope so. It is yes. Let's not take too much time because exam candidates exam is coming up in 24 hours. Yes. 60-year male is present with the intermediate right upper abdominal quadrant pain. So here is the problem. Let me take the highlighter. Here is the problem. Intermediate right upper quadrant pain and ultrasound showing gallstone, this, that, and we can also see the stone, very loud and clear thing. So his liver function tests are normal, so appropriate management in this case. His liver functions are normal. Perhaps some of the other things are normal too. Please, I like to add the patient is vitally stable as well. Okay, which may not mention in this recall, but let's just assume that the vitally stable, because if unstable, everyone mentioned that one after the exam. But if it's like a normal day, people forget to add that one. Now coming to this one, what can we do here actually? Okay, let's assume this is perhaps, if you see the ultrasound actually, they presents with a cholecystitis, perhaps there's presence with a cholecystitis, perhaps. There is a cholecystitis, perhaps, and if you see the ultrasound, it look like what? Can I say it's a gallstone? Can we say this is a gallstone? Yes. So cholecystitis, it can be a presentation of a gallstone. If that's the thing, in that case, recommended a elective. There's some elective procedure recommended to go with a elective procedure, laparoscopic cholecystectomy. We're not going to do it. I mean, we'll allow satelliting down. We can observe for a while, but so elective, much later, cholecystectomy. All good. So B is the correct one, easy one. Normally, ultrasound doesn't come in the exam much except for this two things. One is this one, the gallstone, then another one is a cystic hygroma. It's another ultrasound. Any other ultrasound you guys have seen in exam coming? One to gynae cases perhaps as well, one to gynae cases perhaps as well. Other than not much ultrasound comes actually, as like the X-ray, CT scan, these things are so popular. Other ultrasounds, I mean, it's not much tested other than these two, three things actually. I'll give you guys a list actually in future that what ultrasounds do you cover for the AMC particularly. Next one, is a 65-year female presents with a 3 months history of fatigue, weight loss, intermittent abdominal pain, reports of occasional blood in the stool. Occasional blood in the stool. Okay. Cholesterol reveals a mass in the colon and descending colon. What is the most appropriate next step in the management? So there is a mass. What's the scenario here? So the scenario here, there is a mass. What type of mass? It's a colonic mass. It can be a colonic polyp, and there is a mass, no doubt, actually. So if there is a mass, the question is, what is the next thing we can do? We do have some chemo. Why I would start chemo without seeing its metastasis or not metastasis? Okay, anyways, follow-up colonoscopy 6 months can be a good option, but keep it in mind. Refer to surgical resection. We haven't done the CT scan, so we cannot go for the surgery. Prescribe the iron. Okay, we can do it later. So I think, if we go by exclusion method, the best possible would be that doing a CT scan. Best of it. So it's a colonic mass, suspected a colonic cancer. Okay, if I ask you among the colonic polyps, which type of polyp do you think is the worst one? Okay, which type of polyp? Let me tell you the answer. Villainous, right? There's a term called the villainous polyp actually. So villainous polyps, like a villain, they are the worst one actually. Great. And yes, and among the screening purposes, like villainous, that's the like type actually. And among the if you go to the screening, in that case, familial adenomatous polyposis, it is indicating there is a 100% chance that the next generation may develop this colonic polyps or maybe colonic cancer. Like colonic polyp chances are very, very high in familial adenomatous polyposis. Very popular in the exam. Two things: FAP and HNPCC. Are you familiar with these two terms, right? FAP and HNPCC. Quick question: in FAP cases, when we start screening, I repeat, FAP cases. Okay, let me take a pen and paper to guide you a little bit. FAP cases, when to start the screening. In that case, basically like 10 to 12 years. Anyone you can pick up 10 to 12 years. You can. And HN PCC, in that case, what you can do at the age of 25, actually, as the age of 25. So these are basic. So don't forget to go to RSAGP and also check colon cancer related more details. So you need to perform the CT scan in a way to rule out the staging, if any extension, everything will come out in this case. Some of the very common causes of blood in the stool, one of them would be this particular colonic thing. One of this particular would be the popular one would be, yeah, so here is a popular one too. But there can be many other things. There can be many other things actually. In generally, we call them lower GIT bleeding. Before leaving this slide, there is a popular MC question, which is the number one cause. I repeat, number one cause of lower GIT bleeding. Number one cause of lower GIT bleeding. We're not talking about upper GIT. We're talking about the lower GIT. That is the yes. So number one would be diverticulitis. Again, you need a CT scan. Again, you need a CT scan. So because the person is present with a um, bleeding rectum in any way, or blood is with the stool, so you need a CT scan because diverticulitis also is a common condition. Anyway, so moving to the next one. This question I can expect from you guys to answer. I've taught this one many times in the classes. 70-year male diagnosed with a prostate cancer involving seminal vesicle. Okay, with no evidence of distance metastasis on the imaging. This is the rigorous version. That's how it is coming like that. Normally, they might not mention it's a distant metastasis. Now, the PSA level is elevated, which is itself is an indicator that there is a prostate cancer chance. What is the most appropriate approach or management in this case? Active surveillance, PSA, radical prostatectomy, external beam radiotherapy, androgen deprivation therapy. Now, what to do in this case? Now, final answer is definitely would be this one, external beam radiation therapy. Can anyone tell me why? Can anyone tell me why? The answer for this one, this is like a local meds. Okay. Androgen deprivation therapy, like, when. It is important to know why, it is important to know when. So in this case, the androgen deprivation therapy we can use for the distant cases. So if the distant metastasis, what do you mean by distant metastasis cases? You guys are talented. You guys must be knowing this. A person who is presented with a back pain and prostate related issues. Back pain, prostate related issues. This is high chances. This is very high chances. Prostate cancer metastasis to the bone. So if it is a distant metastasis, what we can go for is a androgen deprivation. What you can go for in this case is a androgen deprivation. So androgen deprivation can be done in two ways. What are the two ways for androgen deprivation? One is a medical, and one is a surgical. Okay, so medical deprivation can be done by, yes, please. Medical deprivation can be done by anyone. Yeah, giving the drug. Well done. Giving the drug actually. And if you want to do the surgery, there's another way. You can do the orchidectomy actually. Removal of the testicle because it is a potential source. So in both way, Is it a removal one or removal the both? That's the question actually. So the difference with a testicular tumor, you remove one and fix another one. Here you remove the both actually. Okay, with or without, keeping the pudendal nerve actually. Okay, it's very important. So uh, it depends on the extent and many things. Some of them can um, keep the pudendal nerve. It's like a more detailing surgery than it is actually. So if pudendal nerve is there, then they will be fine sexually. Otherwise, if pudendal nerve, they're not going to keep it. In that case, sexual function would be affected. Actually, you have to tell the patient to do the surgery. All right. So here is the thing: radical prostatectomy. Here's the thing. So local, the phase two, you are giving the external beam radiation therapy, and the phase two you are giving. Yeah, because you can't provide external beam there, so androgen deprivation therapy as a orchidectomy, so medical, surgical, and wherever possible, I repeat, wherever possible, everything in early stage in that case, radical prostatectomy. Are we clear, everyone, about this question? Are you clear? This was the question. I hope that's clear to all of you. I hope that's clear to all of you. Final summary. This is it was in seminal vesicle. Seminal vesicle is near to prostate. We call it's still nearby. So like a local mets. So if local mets, we treat this condition with external beam radiation therapy. If it would have been going to the vertebra, then I would go for the androgen deprivation therapy. If it's not even in the local mets, everything confined to the prostate, I'll go for a radical prostatectomy. Done. Okay. 8 years, actually. 8 years presence with a routine check. Okay, 8 years presence routine. Her family includes a brother with diabetes and father with colon cancer. Mother is concerned about appropriate screening of her daughter. What is the appropriate screening to recommend this disease? Come on, guys. Yes, please. Okay, so a lot of people are going with A, a lot of people are going with C. Oh, so again, a colon cancer screening related question. Please check one thing. Is it necessary now any screening? That's the main concern. Is that necessary any screening at this point? Have a look on that.